Okay, well, we can go ahead and get started. Hi, everybody. I'm Phyllis Leverich. I'm the Western Slope Outreach Coordinator for the Parkinson Association of the Rockies. Before we start, I would like it to ask everyone to please mute your mic so that we don't have a lot of background noise while the doctor is talking. Um, Thank you for doing that. Also, I have a few announcements I'd like to make. We have our Care Partner Summit on May 10th at the Aurora Hyatt, where we'll have Jane Barton talking about compassion fatigue when it hurts to care, and Kay Adams speaking on power of boundaries and empathy and preventing burnout. Our chats with the Parkinson Pro begin in April, so see our website for details on a chat near you. And our Vitality Walks start on May 17th in Pueblo, with the Denver Walk being on June 1st. If you have a question during the presentation, you can either type it in the chat. There's a little chat icon at the bottom of your screen. You can either type it there, or you can click the little react button where you see the heart and it'll let you raise your hand. Dr. Hawkins, would you like to have the questions during the presentation or all at the end?
During the presentation is fine, and I have the chat open, so I can definitely see that. I don't know if I'll be able to see the hands raised, so
Okay, okay.
just feel free to jump on and interrupt me if there's a question that I missed
Thank you
or
so
someone.
much. Okay, we'll do. So I'd now like to introduce our speaker, Dr. Hawkins, Dr. Trevor Hawkins. Dr. Hawkins is a board certified neurologist with subspecialty expertise in movement disorders. He provides treatment and care for patients with Parkinson's disease, Parkinson plus syndromes, Lewy body disease, Huntington's disease, dystonia, Tourette, tics, chorea, ataxia, restless legs syndrome, myoclonus, drug-induced movement disorders, essential tremor, and tremor. In addition, he performs botulinum toxin injections for neurological disorders and has expertise in deep brain stimulation and movement disorders. His research interests are genetic and clinical causes of ataxia as well as Huntington's disease, and he currently sees patients at UC Health University of Colorado Hospital and at the VA Medical Center. So welcome, Dr. Hawkins. Thank you for being here today.
Well, thank you guys for having me. Yeah. So just like Phyllis was mentioning, this is meant to be as interactive as possible. I'm here mostly as hopefully as a resource to all of you to help answer any and all questions that you guys have, especially as it pertains to the overall medications and different types of treatments for Parkinson's disease. So please feel free to interrupt, ask your questions, ask me to repeat anything in more detail. And then I think I've given this talk almost double digit times now. So I do like having those questions coming at me to keep it fresh, and get at what you guys are talking about and what you're interested in as well too. So without further ado, we'll kind of jump in and get started here. So the hope of what we'll do today, in kind of like in mostly two parts. The first half is going to be just doing a brief overview to kind of set the stage. Hopefully many of you were able to join the first lecture in the series for the PD 101. So we're kind of diving in off of that last talk. And then we'll kind of spend the first half of the talk really diving into levodopa, which is really the center and the hallmark treatment of Parkinson's disease. So we're going to spend a lot of time kind of really focusing on understanding how levodopa impacts Parkinson's. And then the second half of the talk, and we'll kind of dive into the other different medications and how we will come to kind of some basic principles of how we use shared decision making with our patients and come to our decisions as far as treatments go. And then depending on what your guys' questions and interests are, I do have different slides prepared for other types of more advanced treatments as well. But again, the hallmark of this is focusing, at least that kind of get to know, understand the general scene of Parkinson's, especially early on in the disease course. So that's going to be the main focus of today's talk. So I want to kind of briefly show the first picture here that kind of highlights a little bit of the scene of what we're talking about. And so what we're seeing kind of blown up in the cartoon here is our human brain and on the left side. And what's highlighted in that kind of bright orange underneath is the basal ganglia and the brainstem. And those are the structures that are intimately important to where Parkinson's disease occurs. And then on the next, right next to it, we can see that kind of blown up cartoon. And I think, can you guys see my cursor okay here? And you can kind of see what is a blown up cartoon of a neuron. And these are our nerve cells in our brain. And this is actually how our nerve cells talk to each other. So essentially how they work is they spit chemicals back and forth called neurotransmitters, which are essentially our chemical messengers. And they deliver that chemical signal from one cell to the next. And that's how our brain cells kind of communicate with each other. And so this is going to be kind of crucially important to understanding not only what goes wrong in Parkinson's, but then also why do our medications work to kind of help close and can treat the symptoms of Parkinson's disease. So we'll come back to this later to kind of understand how that cell-to-cell communication is disrupted and also repaired with our medications in Parkinson's. So just to kind of remind ourselves a little bit about the pathology of Parkinson's disease. So we see kind of a cutout in the brain here, and we see this dark substance called the substantia nigra. And it's loss of these cells in the brainstem, as we can kind of see highlighted here, that is the hallmark feature of what leads to Parkinson's disease. And in particular, these cells are responsible for secreting a chemical messenger called dopamine. And dopamine loss is what leads to the symptoms of Parkinson's disease ultimately, and especially the motor symptoms. And we've known this going all the way back to the 1950s, that they were able to kind of pin down and discover that dopamine loss was that hallmark feature of the disease. And so we've actually had the first available treatment going all the way back to the 1960s. So what does that really mean? And long story short is we've had a lot of familiarity with the mainstay of treatment for Parkinson's going on almost 60, 70 years now that we've had experience working with it. So we understand quite a bit about its pluses and its minuses at this point. Another key thing to kind of keep in mind is that dopamine has other pathways in the brain outside of just being used in the pathways involved with Parkinson's disease. So we can see highlighted here, the nigrostriatal pathway is the one involved in Parkinson's, but we have these other pathways like the mesocortic and the mesolimbic. These are kind of actually better known in layman's terms as the reward pathways in the brain. So this is the kind of the reward stimulation pathways where you might kind of hear, oh, I need to increase my dopamine, or I have too much dopamine in my system. That's from these other pathways that can also occur in the brain. And this can actually become important to understand some of the offsite side effects of some of the medications that we'll talk about later. But again, in Parkinson's disease, it's actually loss of this isolated dopamine pathway, the nigrostriatal pathway, that's relevant to us. So again, many of you are probably unfortunately experiencing some of these symptoms, but just to kind of highlight the different possible symptoms of Parkinson's, they can be kind of generally broken down into two big categories. We have our motor symptoms, which again are kind of our movement symptoms. So these are things like your tremor, the slowed movement, the stiffness. It could also be gait impairment or balance issues and others as well, such as difficulty swallowing, changes to your voice, etc. Then we have our kind of non-motor symptoms, which could be equally problematic, if not more so, such as mood, memory impairment, psychosis. These are all kinds of things that can be very important and do potentially have treatments for Parkinson's. But the mainstay of today's talk is going to be kind of focusing on the motor symptoms. So a lot of the medications we're discussing here are focused on motor. We can almost do a whole separate talk, and certainly, hopefully, if you guys are participating with PAR, with your local support groups, we'll be able to always offer talks further down the road about the non-motor symptoms of Parkinson's disease as well. So why can't, if my problem is simply that I've lost dopamine in the brain, why can't I just then take more dopamine to kind of make that up? And the reason why we cannot do that in our brains is we have this shrink wrap, kind of this barrier around our brains. Because one unique feature about our brain compared to the rest of our body is when we lose those brain cells, they don't regenerate. So just like when we get a cut on our skin, the skin regrows and repairs itself. Most of our organs and other tissues in our body have ability to regenerate once they're damaged, but our brain does not. I mean, and that's why we have to have this extra layer of protection. So all those environmental toxins and bugs and bacteria and all those things that can kind of get in elsewhere, we have to be extra careful to make sure they can't get into the brain, because the stakes are much higher, because once we lose it, it's gone. So that blood and brain barrier is what we refer to as that shrink wrap that kind of helps to be that extra layer of protection to keep all the external environment out and protect our brain. And in particular, it really wants to tightly control that chemical messenger system because we're talking very, very small amounts of neurotransmitters, neurochemical cells that can ultimately do it. Oh, I think there's some people that forgot to mute.
Do I have to go to Bluetooth settings?
Yeah, did you not do that?
No.
Oh.
I'll pause here while they're trying to figure out how to mute. Yeah, I think they figured it out. Yeah. But again, so we have our shrink wrap layer around our brain, and it wants to really tightly control these chemical messengers. Because if all of a sudden the system gets flooded with an inappropriate high amount of chemical messengers, that communication kind of breaks down. Yeah. So almost all neurotransmitters, such as dopamine, cannot just freely get in externally straight into the brain because it's going to mess up that cell-to-cell communication. These are why you see things kind of over-the-counter memory supplements, why many of them don't work, is because most of their ingredients actually cannot get into the brain. It's also true for many other medications about why they have to be specialized if they're going to work in our brains, because they have to have this extra ability to get through the blood-brain barrier. So what we were able to figure out all the way back in the 1960s is we actually were able to kind of move move backwards in terms of the production of dopamine in our bodies to find a precursor that actually freely passes the blood-brain barrier. And that's what levodopa is, or L-DOPA for short. It's able to cross freely into the blood-brain barrier. Then those nerve cells that are trying to make that dopamine for you, those dopamine-producing nerve cells, can turn that levodopa into dopamine, and that increases its load. So that's what we were able to figure all the way back in the 1960s is what was that precursor that actually allowed us to get those brain cells that want to help us make more dopamine, get that dopamine into the system. And so that's why it's kind of the mainstay and why it's kind of the most direct pathway is that basically it's our way of replacing the dopamine that we've lost. So to kind of highlight that in a few different ways, one way to conceptually think about what our different options are is our kind of our menu or our playlist here. So if we know our problem is that we've lost dopamine, we can simply replace it. We could also make a chemical that looks and acts like dopamine, so we can kind of mimic dopamine. We can try to prevent the breakdown of the dopamine that's still around, because it's certainly not all the dopamine's gone. It's just diminished. So we could try to kind of keep what's still there around. We could try to protect dopaminergic neurons from continuing to die. And this is the holy grail, so to speak, of Parkinson's. Can we actually stop disease progression? Other than exercise, this does not exist in our arsenal currently. So exercise is crucially important. And I like to highlight here, that's the only way that we know of what we can do so far to protect neurons from dying. We could regrow dopaminergic neurons. Unfortunately, we have not cracked the code on that yet. All stem cell therapies and everything else up to this point have been negative, and they do not work for Parkinson's disease. Or we can modify neuronal circuitry, and that's where we talk about deep brain stimulation and some of the other ways where we can actually try to manipulate other pathways in the brain to kind of work around our dopamine problem. So again, this is kind of our menu of different ways that we can approach this. So let's kind of take a quick look here at the overlay of the medications that are available to us. And this is pretty much mostly comprehensive. There's actually a few more that just got approved that we can even add to this list as we speak. And one of the nice things, the problems that we have in Parkinson's is that we potentially have a lot of options that we can use at our disposal. And we'll talk again a little bit in the second half of the lecture about how we choose from this menu. But I want to highlight here at least the different potential options. So we can kind of see the names, and we're going to walk through these kind of one by one. And you can see what's highlighted in the blue box are kind of your big guns, your bigger efficacy medications. And everything else outside the blue box is kind of more your fine tuners, more kind of like your small changes, but they also have less side effects. So that's kind of our two general camps. And again, we're going to come back to this slide again and again throughout today's talk. So now we're going to kind of remind ourselves, again, we're going to dive into this nerve cells communication and how they kind of communicate with each other. And essentially what we can kind of see outlined here is we have kind of our, if we imagine this is our dopamine producing cell, and then we have our cell that it's trying to talk to, and then we have the space between where it shoots out these chemicals is called a synapse. So you have the pre-neuron, the post-neuron, and the synapse are kind of our three different steps in that communication process. So we can have the beginning, the middle, and the end. And we can kind of see that in kind of a simplified cartoon here. Again, the beginning, the presynaptic neuron, the middle, that's synapse, and the postsynaptic neuron over here. And so these are the three different steps that we could potentially intervene. And you can see highlighted here is where these potential medications interact within that beginning, middle, and end. So you can actually theorize why you might want to be on more than one medication, because these medications can actually work synergistically with each other. So you could guess they just like, well, why wouldn't I want to be on a medication that works in the beginning? Then I can also be on a medication that works in the middle. And I can also be on a medication that works at the end. Synergistically, they can all work together at those different stages to kind of come together for a good solid treatment. Yeah, again, we're going to break this down a little bit more in detail as we go through today's talk. And then this is kind of like the more direct cartoon of the same thing where we can kind of see again the beginning, the synapse here, the middle, and then the postsynaptic neuron here. So let's kind of give you another analogy to kind of understand these different stages and how we would interact in that beginning, middle, and end process. And the analogy I like to use is thinking about a newspaper salesman or a newspaper boy trying to deliver that newspaper to you. I don't know how many more years we'll be able to actually use this now as far as who actually gets newspapers delivered, but hopefully many of us have experienced this at some point in our life. And if we imagine our neurons being those newspaper boys, they're trying to deliver that message, that newspaper, which is dopamine. And then we have our natural enemies to the newspaper boy. We have our newspaper thieves, and we have those dogs sitting on that porch scaring those newspaper boys from being able to deliver it. And then ultimately that target neuron, that mailbox is trying to get that paper delivered. So that will kind of set the stage here. So what's happening in Parkinson's? We're losing those newspaper boys. So we have less newspaper boys now to try to deliver that message. So the system is now stressed to be able to try to deliver those newspapers. So now we have our disease state. So what can we do to help solve that problem? Well, one way that we could do it is giving those remaining paper boys that are still around, let's give them more papers. So let's have them increase the amount of papers that they have, and they can kind of pick up the slack to be able to try to deliver that message. This is what levodopa does. It's giving more dopamine to those newspaper boys, more newspapers, so they can increase the amount that they deliver. So that's one way that we could try to combat this. Another way that we can do this is mimicking dopamine. So again, we might not be able to get as many newspapers out, but maybe we can deliver a message that's very similar to the newspaper, but a little bit different and works through a different pathway. That could be something like magazines, which again might have a very similar message, but no longer delivered by the paper boy. They're delivered by the postman. And the postman is an expert. He knows how to dodge the dogs. He knows how to dodge the mail thieves. He's been on the block for a while. So he's able to get that magazines directly delivered into the mailbox for you. So essentially, again, similar message, different delivery route that kind of bypasses the issue and ultimately gets the message delivered. Another way that we can also do is eliminate those newspaper thieves and eliminate the dogs scaring away. So we increase the ability, the efficiency of those newspaper boys being able to deliver that message all the way through. So we can stop that kind of the natural enemies here and increase the efficiency to deliver that message. So again, we can kind of either mimic dopamine or replace the dopamine, mimic it through a different messaging system, like as opposed to newspaper delivering a magazine, or we can kind of eliminate those natural enemies of the newspaper boy and allow more efficiency to get delivered. So that's essentially our three different main strategies that we use to try to help our dopamine problem in Parkinson's. So now we've set the stage of what the different medications potentially could do. Let's take our deep dive into levodopa. Because again, this is our gold standard. This is our hallmark. This is our center core treatment for Parkinson's. So what does it do and what does it not do? What are the kind of the pluses and minuses? Well, what it really has been proven to shown again and again, and what is kind of the definition of Parkinson's is that you have symptoms that respond to levodopa. And those symptoms are your slowness of movement and your stiffness. These almost always or should consistently respond. If they don't, that's usually a sign that it might be something that's not Parkinson's disease, and it might be a mimic or other disease. The ones that are unfortunately a little bit more variable, they can respond, but it's not necessarily a guarantee, is gait instability or freezing of gait or kind of gait problems, so walking troubles, or the tremors. Interestingly enough, tremors might only respond about 60% of the time. So about almost half of patients with tremors or Parkinson's may have a poor response to levodopa. So it's important when, especially if you're starting out on medications, to not only pay attention to one symptom, but pay attention to all your symptoms to try to see if anything is responding to the medication. This is something that we spend a lot of time talking about patients that see us very early in the disease course, because you might kind of think you're not responding if you're only paying attention to tremors, for example. So you definitely want to make sure you're paying attention to kind of the other symptoms. And if you're ever unsure, that's an important thing to talk about with your providers. When I take these medications, what am I looking for? What am I trying to see gets better? And that's something that we can sometimes even measure in the clinic, where we have patients come back on medications that can help kind of show patients what they're responding to. And then the questionable benefit, again, this is almost like I like to think about it as a bonus, because it can actually help some of these non-motor symptoms, but that's really a nice kind of cherry on top. If it actually helps with these, we don't necessarily expect it to. But many times patients will report that their non-motor symptoms are better when they get started on levodopa as well. So that's kind of what it's good at. Some of the common side effects, what the downsides are, the common things being common, the most one far and away is, especially when you first start taking the medication, is nausea, which is upset stomach or vomiting. The good news is that this is usually transient. It usually only lasts for a few weeks. Then once your body gets used to it, even if you quadruple the dose, it doesn't come back. So usually that's only important in the early stages. Unfortunately, there is about 5% of patients that have continuing issues. And again, there's ways to troubleshoot that if it ever does occur. Now, another one is dizziness when you change positions. This is like all of us right now as we sit down here, all on our chairs. If we go to get up at the end of today's talk, we could get a little bit dizzy when we stand up too fast. And the levodopa can sometimes make that worse. And then it can sometimes induce vivid dreams. This is something that really is only relevant if the dreams are particularly bothersome. But definitely a lot of patients will notice this. And then the rare side effects, but these are probably the more problematic ones for many patients, are dyskinesias, which are kind of excess movements. And we'll take a look at a video of Michael J. Fox in a little bit to kind of show what those look like. And then hallucinations, like seeing things that aren't actually there, is the most common. Those are obviously a little bit more problematic, but thankfully a lot more rare in terms of their occurrence. And one important thing to keep in mind is all side effects of levodopa are reversible, meaning that if you ever tried it and noticed side effects, you could lower down the dose and those side effects will go away. So it doesn't cause any permanent damage to take it. So it is very reasonable to sometimes give it a try. But just like with any medication that's out there, unfortunately, these days, there's always some myths that kind of permeate across the different either medical literature or also just colloquially in the community. Some of this actually comes from the fact that in the 1960s and 70s, we had some theories about levodopa that, given the next 50 years, we were able to prove false. So a lot of the myths you can see here, levodopa can cause symptoms to get worse or actually be toxic to the brain. It actually, thankfully, has no worsening or toxic effects at all in terms of progression of the disease. Also, unfortunately, it does not slow down disease progression. So it helps manage the symptoms of the disease, but it does not stop cells from continuing to die off. And so that's an important feature with levodopa. So the good news is it doesn't hasten or progress the disease faster, but it also, unfortunately, does not slow down disease progression. It does, like they used to think that it had a shelf life, meaning that you would not want to use it until you were very desperate into the disease course, because once you start to use it, it would only work for several years and then not work anymore. So what we learn is that we've had patients on it now for 40 plus years, and it continues to work even 40 years into the disease course. So there is no shelf life. There's no, oh, I better keep it on the shelf until I absolutely need it. Once you start using it, it'll continue to work for you throughout the course of the disease. Sometimes we hear about levodopa being an artificial chemical or just kind of an in general apposition to being on kind of prescription medications. Levodopa is actually a natural occurring chemical. This is something that actually can be harnessed in nature, and essentially all it is concentrated into a pill for you. And then the other thing is that sometimes levodopa, like as soon as I start taking it, I increase the likelihood of having side effects like dyskinesias. And that's actually not true either. The longer you're on the medication does not really change when the dyskinesias are going to occur. Dyskinesias actually happen as a result of the disease course itself. So let's take a look at all these, especially those dyskinesias. So this is actually a study that was done several years ago now, actually almost a couple decades. And it was basically looking at two groups of patients. It looked at an Italian group of patients and a group of patients from a country in Africa called Ghana. And essentially, the group in Italy had great access to medical care. The group in Africa, not so great access to medical care. So what we're seeing here is when those patients got started on levodopa. And you can see in the Italian group, about 3.5 years into the disease course, they started their medication. Now, unfortunately, for the Ghanaian group, they didn't get the levodopa until about 6 years. So because of that delay in access to care. And then despite having that extra almost 2.5 years of being on levodopa, the dyskinesias actually started within 6 months of each other. So the Italian group started about 6.5, and then the Ghanaian group at about 6.5 to 7 years. So even though they were only on it for a year, the dyskinesia started essentially right away, where here they were on it for several years before the dyskinesia started. So what do we really tell from this? The dyskinesias were how long you had the disease, not how long you're on levodopa. So that's what we're able to take away. And wouldn't it be nice to be getting that benefit in this sweet spot here where you're able to take advantage without having those side effects? So again, what's the kind of takeaway? There's no reason to delay. If you have symptoms that bother you, then you can take the medication early. You're not setting yourself up for failure down the road. So what is a dyskinesia? We can have Michael J. Fox show us.
I just made it up.
Yeah. But is it John?
No, it says no, my middle name is Andrew. It actually stands for genuine or genius, whichever one you like.
Okay, we're not getting anywhere here.
There was a Michael.
So he's actually telling David Letterman a story about how Jay was just a made-up initial and his middle name is actually Andrew. But there was already a Michael Fox, so he had to change his name for the Screen Actors Guild. But you can see those kind of constant fidgety movements where he's not able to sit still. That's that levodopa-induced dyskinesia from too much medication. I do like to highlight here too, this is something that I've learned as a Parkinson's disease expert and where I get to talk to patients at all courses of their disease. The anticipation of dyskinesias in 95% plus of cases is always worse than the actual experience for patients. Meaning that only about 5% of patients actually find dyskinesias bothersome when they start to have them. Why? Because they're involuntary. So all of us look at people that like Michael J. Fox in this video, and we assume he's restless. We assume he's uncomfortable. He isn't even, most of the time can't even tell he's moving. It's very subconscious, out of sight, out of mind. And I like to bring that up because, again, I think it looks really scary. It can kind of cause people to avoid taking the medications that can help them. But oftentimes when they start having the dyskinesias, they're not so bad. They're not bothersome. And most patients are like, yeah, that's fine. I don't need to worry about those. Because the benefit they're getting from the medication to treat those symptoms like the slowness, the stiffness, the tremors is worth any even annoyance of having those dyskinesias. So I do like to dispel that one just because I've had patients share that over and over and over again with me, that the dyskinesia is always in hindsight were nowhere near as bad as what they thought they would be when they started to have them. So something to kind of keep in mind in case that was, would make you kind of have trepidation of starting on the medication. So now kind of like looking a little bit at the formulations of levodopa, because can be a little bit confusing because essentially we've had this around forever and we have a lot of different formulations that all are essentially the same thing. It's still levodopa packaged differently in different forms of medications. So you might kind of hear different names of it. And actually the original name of it was Sinemet, and we still use that today for the most common forms of levodopa. And cinema actually is Latin for sin and without emesis, which is vomiting. So they literally named it without vomiting. Why? Because if it's actually without the carbidopa, which is basically a drug that helps it make it to the brain and not get chewed up in the gut on its way up to the brain, then it can cause a lot of more worsening of that nausea and vomiting. So when they actually added the carbidopa, they kind of solved a lot of the problem with the nausea and vomiting from taking levodopa. And that's why they named it in Latin without vomiting. Yeah. The movie Awakenings is actually about this too with Robin Williams, in case you guys are ever interested. It's about the discovery of levodopa, as an aside, in case you guys were interested. So some of you may have heard about Mucuna pruriens, which is kind of a natural product of levodopa. That one does not have any carbidopa. So that one absolutely has problems in terms of that reliability and other side effects, especially if you take an equivalent dose. You have to take 100, if not 1,000-fold much more of levodopa because you don't have the carbidopa with it. And it's exactly chemically, structurally the same as what's in the different formulations in your pills. So the pills are a much controlled level of levodopa. So just in case you guys ever came across that, there really is no advantage to taking the Mucuna. It's just a less reliable version of your levodopa. And so you're going to see a bunch of different names that you can kind of see on the right here. There's immediate release, sustained release, extended release, combined with other drugs. It could be inhaled. It can go through feeding tubes. It can go through skin pumps. So there's a lot of different versions because we know it works. And we'll talk about why all these different versions exist. But to kind of set the stage, I think to understand a little bit, the most common one that many of you guys will be on or maybe already are is the immediate release Cinemets or carbidopa levodopa, which are usually yellow. So your yellow tabs are going to be kind of your standard. And then we'll see a bunch of different names that refer to the controlled release. And this is one of those unfortunate situations where there's not great regulation. So controlled release, sustained action, some extended release preparations, you'll see ER, XR, unfortunately, all mean the same thing. And I hate to say it, but I think most of us in this room, if we heard controlled release, sustained action, extended release, we think that means it lasts longer. It doesn't. It just means it absorbs more slowly. So that's something to keep in mind. We'll talk. We're going to take a deep dive into that. They do make combination products with other medications, and we'll talk about those a little bit in detail. So products like Stalevo, for example, is still carbidopa levodopa, just packaged with other medications. So kind of all names of the same thing. And then we have true extended release preparations. We have Rytari, which has been around for almost a decade now. And then the brand new one that just came out a few months ago called Crexont as well. So these are kind of true mixtures of extended release carbidopa levodopa. So I think one kind of illustration about why all that matters, why all these different formulations of the drug. And what we have here, if you can imagine, so this is the medication in your brain and your body. So this is where you kind of take your pill, the levels increase, and then eventually kind of your body processes it and works its way out of your system. And so early in the disease, you can kind of hit that sweet spot in this green area pretty easily. No matter how you kind of take that pill, it stays nicely in the green. But unfortunately, as the disease progresses, that window where that medication hits that nice green area narrows. So we need more. We need more medication to get it replaced because we've lost more. But also what's there can easily be overwhelmed. And that's where we run into side effects like dyskinesias. So we can see, unfortunately, it narrows on both sides. It narrows not only where we need more medication, but it becomes easier to have side effects over time. So that's where it becomes important, where if you just took the same pill throughout your disease course, it works great here. But as the disease progresses, we need things that can kind of stay in the green more efficiently. And that's essentially why we have these different preparations. So this is that same kind of concept here. So if we kind of put in our lines, if we imagine this is the amount of time, this is that blood concentration or how much drugs in our system. So if we imagine that between the red lines is that green box that we were just looking at, this is what it looks like when we take a pill. And so what we're seeing here, the different formulations of levodopa, in how they kind of enter and exit into our systems, what we call the half-life of the drug, essentially, like how quickly it kicks in and wears off. So the first peak we see here, these boxes, these squares, is your immediate release intimate. And just like its name, it immediately releases into the system. So you see this nice quick peak, but it can easily sometimes overshoot and then it wears off at about that 4 to 6 hour mark. So this is why you would never take this once a day. You would never take it twice a day. You would take it 3 times a day to kind of cover you for that 16 hours that you're awake, because it lasts about 4 to 6 hours. And then we see our controlled release preparations. And again, controlled release, unfortunately, can mean the same thing as sustained action, ER, they all mean the same thing. And that actually only makes it last maybe about 10, 15 minutes longer. So that's something to keep in mind why we use immediate release for the most part versus controlled release, because the controlled release actually doesn't really last longer. You can see it takes longer to kick in, which is where the controlled release part comes in. So by the time it's actually kicking in, it's already wearing off. Yeah. Yeah. Some of our patients like to joke when I talk about this with them, that the CR doesn't mean controlled release, it means crappy release. And that's not unfair. That's actually what happens. Is they kind of, when they made this in the 1990s, they realized, whoops, we were trying to make something that lasted longer and we didn't get it right. Then we see actually out here, the entacapone, which is that medication that helps the levodopa last a little bit longer. We'll talk about later, which is the Stalevo product. So yeah, a little bit longer, but still not much. We're maybe getting a little bit, like a half an hour or so. And now we have the extended release, which in this case, this is Rytari, but Crexont does the same thing, where now we're starting to really see a difference where we're actually starting to see maybe even several hours longer of the medication being in the system. So this is essentially kind of what we're dealing with when we're having these different preparations, is we know that, okay, the Cinemet works, but it's only going to last a few hours in the system. So how do we kind of keep that medication in the system, especially in that window, is really where the art of the medication treatment comes into play. So we can kind of, oh, sorry, I think I had some more arrows here, but we already talked about all these things. So now kind of jumping a little bit to some of the highlights, some of the big takeaways for you guys in terms of why the do's and don'ts of levodopa. So many of you guys may have already heard about this and the interaction between levodopa and food. This gets into how levodopa actually gets into our systems. So all of our medications, pretty much most oral pills, dissolve in our stomach, and then they have to pass into our intestine, and that's actually where they get into our bloodstream. So that's why it takes about a half an hour for almost all pills to work, because they have to get dissolved in our stomach into our bloodstreams, and that usually takes about 20, 30 minutes to do. And then once it's in the bloodstream, it can traverse freely up into our brains and replace, like we talked about. So interestingly enough, levodopa looks identically similar to the breakdown products of proteins in our system. And the breakdown products of protein are called amino acids. You guys may have heard about this going all the way back to grade school, those essential amino acids and those building blocks for the proteins in our cells. And so essentially our gut does not differentiate, does not have any specialized transporters just for dopamine or just for levodopa or just for amino acids. It has one for all of the above. And so basically, if you have a bunch of amino acids at the same time levodopa is trying to get in, and the gut gets overloaded, and a lot of that medication keeps going right on down and ultimately out in your stool. So essentially, if you have a bunch of amino acids with the levodopa, you can decrease the amount of medication that gets into your system by about up to 30%. So the other part, though, is that when you take it with food, that's a great way to curb the nausea and vomiting. So it's totally okay to take levodopa with food. So I think this is one of those misnomers that we see. And down the road, it's great practice to be able to take it on an empty stomach because you kind of at least control the absorption. But it's not dangerous. It doesn't cause any toxicity to take it with food. This decreases the absorption a little bit. So early on, I always tell my patients, always take it at least with a snack, because that's that window when you are at risk for having the upset stomach. In a perfect world, If you can actually get it with a non-protein based snack, like a carbohydrate snack, like bread products that you see here, that's even better because now you're kind of the best of both worlds. You have a snack that can decrease the nausea, but it's not going to interact or decrease the absorption either. Yeah. So again, in a perfect world, we can kind of work on some of these best practices, but at the start, it's okay to take it with food. Okay. Now down the road, like if you're able to get to the point of being able to take it on an empty stomach, usually we say leave it about 30 minutes before a meal or about 1 to 2 hours afterwards. And that's going to be the kind of the cleanest way to make sure it's not interacting with any kind of food in the stomach to decrease that absorption. But I can't stress this enough, probably like in my personal experience, this gets overthought as opposed to underthought, meaning that most patients actually do too much to avoid taking it with food, where the whole point of these medications is to kind of improve your quality of life. So sometimes keep it simple. If you're in most days, you can kind of set up a routine where you can kind of get it on empty stomach, great. Life happens. Whoops, I just took my pill and I'm sitting down here for lunch. Whoops, I just ate lunch and I forgot to take my pill. That's okay. It's way better to have 70% of a medication than zero. Yeah. So you would not wait an hour to take your pill if you were late for it. You take your pills on time. Okay. Some other points. Again, almost always a Parkinson's expert's going to start you on the 25, 100 milligram immediate release tabs. That's because they're kind of they're cheap. They're the easiest to use. They're the easiest to kind of manipulate if you're trying to change the dosing. So almost always that's our gold standard at the start. That's also what your insurance companies want you to do too. Because it's the old kid, it's the cheap one. Again, 3 times a day, because it lasts about that 4 to 5 hours. So there's no reason to really do it less than that at the start. Again, we already talked about the food and the nausea. And again, remembering that carbohydrate snack is always very reasonable, especially at the start when you're in that window for the nausea. And there are different times where we might not start with immediate release. Like a good example would be patients that are over the age of 90. And that's because, again, they can fall asleep when it kicks in too fast. So we actually take advantage of the bad absorption of the controlled release so it absorbs more slowly. So you might have some of these kind of weird situations where, again, about 1 to 2% of people can actually have an allergic reaction to the yellow dye. So they might just need a different kind of pill to avoid those interactions. So there's definitely some exceptions about why not every patient would start on the 25 100s. But for the most part, that's kind of our gold standard. All right. So in the last couple of minutes here, now we're going to kind of take a look at some of the other versions of levodopa a little bit more in detail. So one way that we can also get levodopa into the system is actually inhaled through the lungs. So unlike having to go through the stomach, this one is able to bypass that need for digestion. So it goes straight from the lungs into the bloodstream up to the brain. So what's the good part about that? It goes fast. So if you need something to kick in now, if you're pretty miserable, then you can have something that kicks in 5 to 10 minutes as opposed to 25, 30 minutes. And the downside is it also washes out of you a lot faster too. So this is really used as what we call a rescue medication, where it's like, I don't know, this isn't going to be great for trying to last, for several hours throughout the day. But let's say my medication doesn't work. Let's say that my dose wears off unpredictably and I'm feeling pretty miserable in the moment. This can be used to rescue you out of that kind of issues in the moment. So there's different reasons about why you might use this down the road if you're having those kind of unpredictable offs or bad off times where you need something that works fast. The other one that's been around for a while is the gastrointestinal infusion, where essentially what this goes through is a pump that pumps in a steady amount of levodopa. So unlike having to take a pill where you get a big bolus of medication and then you kind of wait for it and then you have to take another big bolus, this one kind of just infuses a steady amount throughout the day. And what's kind of a bummer is it has to go through the feeding tube. So most patients, that's the holdup on this one, is dealing with the feeding tube. Thankfully, now we have kind of just freshly on the market and FDA approved the subcutaneous pump of levodopa. As you can kind of see in the picture here, It's again a little bit of a pump that puts out a steady amount of levodopa, but it's just a little patch, a little cannula through the skin. And this is actually very, very similar to diabetic pumps. If you have ever come across anyone with type 1 diabetes for their insulin pumps. And it's the same kind of idea where they can infuse levodopa through the skin in a steady amount. So it's a nice way to kind of control the amount of levodopa you're getting. So stay tuned on this one. This one is definitely not commercially available across the board. If you're over the age of 63, you can't get this. So eventually that might get worked out, but it's not available yet. So it's something to kind of think about for in the near future here. What's the real downside to it? Is it really that you can have interactions or breakdown of the skin? Sometimes it's a little nodules or kind of discomfort. Other times it can get infected. You need some antibiotics or other things to kind of help those skin infections. But otherwise, it works really nicely in terms of being able to get levodopa into your system at a steady rate to kind of avoid that kind of peak and valley with the oral medications. So this is actually not a bad stopping point if we wanted to kind of take like a couple minutes. And please, 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 I've seen no questions yet. I'd love to have some questions here about any of it, especially about levodopa. And also feel free to kind of stretch, run to the restroom, and then we'll kind of can come back in a couple minutes here. But please, anyone has any questions so far?
Dr. Hawkins.
Yeah, go ahead.
I'm sorry.
Hmm?
I was wondering two things. I had someone talk to me about the is it Vialev?
Yeah, the pump.
Yeah. I know right now it's not Medicare approved, so the cost is pretty prohibitive with the exception of some folks. There are a couple of people that pay for it out of pocket at about $11,000 a month is.
Yeah. And I personally, like my recommendation, it's never going to be worth $11,000 a month.
Yeah.
So I would definitely recommend everyone to wait. Thankfully, we have other options.
Do you anticipate Medicare taking this up on their formulary anytime soon?
Yeah, soon is always the operative word. Because again, with our government going through transitions and everything, you never know 100% of when all that's going to be worked out. But I think eventually it will be. There are isolated situations, like for example, like controlled systems like the VA, like the Veterans Affairs, will have this probably available sooner to some certain populations. And if you are under the age of 63 and on private insurance, meaning like not Medicare, it is potentially available as well through the company. So certainly if anyone on the call would meet those two criteria, that potentially is an option. But the way I kind of think about the pump right now is this would be something where the oral medication somehow failed you. And probably all insurance companies, including Medicare, will require that. So this would not be what you start on. This would be what you would advance to if somehow the oral medications were not doing what you wanted them to do.
Okay. And the other part, I was at a support group yesterday and a gentleman said that he had been talked to about the patch and it seemed to
The
him.
patch does not levodopa, so actually hold
Okay.
that thought because we're going to talk about the other medications in a little bit.
Okay.
Yep.
Okay.
Including the
And
patch.
yeah, he said, when's that happening? And so, all right. Thank you.
Yep, both great questions. And then I see Michael put a question in the chat. I'll read it off to you just in case anyone's not able to see the chat question. So he asked, what else do we know about the inhaled version of levodopa? His mother has stomach issues and wondering about good alternatives. Would the inhaler be considered a replacement? No, it is absolutely not, because it only works for about a half an hour to an hour at a time. It is never going to be your hallmark or your backbone. It's only good to kind of fill in the gap, so to speak. So certainly if there are stomach issues, then the pump that we just were talking about is one potential way to reroute levodopa, or sometimes that's where we'll use the other different classes of medications to try to work around that issue as well. So a lot of that depends on what do you mean by stomach issues. Like, is it just side effects from the medication, or if there's other issues going on too, depending on the situation. You might have different options. Like Kim just mentioned, like one of them has a patch, and that we'll talk about in a little bit here. But no, the inhaler would never ever be the hallmark feature. The other part about why you can't just take the inhaled version is it doesn't have carbidopa with it. So it works nicely if you're taking oral carbidopa, and then the inhaled levodopa works just fine. But we can't do an inhaled carbidopa. So really, if you take it by itself, most of it's going to get chewed up unless you're also taking some oral medication to help you. And then Maureen asked about Rytari, which is that control release, rasagiline and amantadine. So again, part of the reason why is that every patient's going to have a unique set of circumstances that's going to be shared decision making. So we're going to talk about why that's the case. But almost always, it's reasonable to be on different medications, like we were showing at the beginning, where they can work at different points in that system, that kind of beginning, middle, and end. And we're going to take a look, especially at the rasagiline and the amantadine, a little bit here. All right, so hopefully everyone that wanted to was able to do a stretch break. So kind of jump back into it here. And again, a perfect lead in bringing up those other medications, because now we're going to kind of talk through some of those other classes of medication that kind of work along synergistically with levodopa. So the first group are going to be our mimics, our dopamine mimics. These are our magazines as opposed to the newspaper. So they get kind of delivered in a different way, but they're going to look very similar to dopamine in our brain. So they kind of deliver a similar message. So what we call these are dopamine agonists, and agonists are basically another way of saying they act like dopamine. And so you can see the different names that are up there as well. And it comes in different pill formulations, including like once daily extended release preparations. And then just like Kim kind of highlighted, it comes as a patch. The Nupro, the retigating comes in a patch form. And you can also do actually a subcutaneous injection, almost like an EpiPen, if any of you ever seen those for people with allergies. That's used just like we talked about the inhaled levodopa for a rescue dose. So there's actually a rescue dose version of it. And just approved 2-3 weeks ago, I think at this point, is a pump. Very, very similar to what we just talked about, the levodopa pump. There's actually an apomorphine pump that it's going to be available in April. So same idea about kind of having a steady amount of infused throughout the day. So what's kind of the advantages, disadvantages of dopamine agonists versus levodopa? Well, the advantages are very, very similar in terms of it can improve the symptoms. Not quite as good as levodopa. It's not quite as potent in terms of that, but it can come close. So a lot of the same symptoms, the tremors, the slowness, stiffness, all that gets better. And again, probably the most important advantage for most patients why we would use these is it's less likely to induce those levodopa-induced dyskinesias. So that's a particular problem or has been problematic. That's one of the most common reasons why we would use the dopamine agonist. So again, some advantages. It has the patch version. So for example, if you had stomach issues or couldn't swallow pills, this might be a time where we would use the patch version to kind of route around the stomach. So it has some advantages as well in terms of the different styles and different formulas. But it does carry some side effects that are relatively unique to the dopamine agonist, especially compared to levodopa. The two that we worry about the most, I should mention too, it has a very, very similar side effects. It can induce nausea, it can induce the lightheadedness, similar to levodopa. But the two that it can induce way more frequently than levodopa itself are sleep attacks, which almost look like narcoleptic attacks, where you can kind of fall asleep when you're at a stoplight, fall asleep in the middle of a conversation. So that obviously can be pretty problematic, especially if you're driving or trying to work. And probably the one that is the biggest nuisance, though, is what we call an impulse control disorder. And you can see that kind of in my cartoon over here, kind of a cartoonized version of what we mean by that. So these are essentially like kind of uncontrolled impulses where it could either be hypersexuality, buying prostitutes, pornography, binge eating, gambling, some of the more recent examples, spending all kinds of money on Candy Crush online games, getting catfished more easily, and giving away your life possessions to some supposed girlfriend in Africa. All these kinds of things are become a little bit more problematic. And again, it's these kind of compulsive, impulsive behaviors usually. Not always is that going to be a bad thing. I have like one example of a patient whose impulse control was that she had to clean her house every night. But the only real side effect of that is that she had a really clean house. So no one was really that upset about it. But again, you can easily imagine if you get the wrong impulse, it can be pretty problematic. So the important thing is for all my caregivers that are in the room, the patients themselves, funny enough, don't pick up on this. They just start having the impulse and they just feel like it's a normal thing. But man, to the caregivers, to the family members, they see right away, oh no, this isn't normal. So it could be things like, you used to buy one pair of shoes, now they're buying 12. Or again, all the different examples we talked about. So it's important if you have any of your loved ones or you as a patient are on these class of medications, that someone is keeping an eye on you. Someone's checking in to make sure these impulse control issues aren't happening. I hate to say it, it can kind of come up at any time in the disease course when you're on these medications. Those can kind of pop up. And they're not necessarily dose dependent either. They're kind of idiosyncratic. And what we mean by that is they can kind of happen or they don't. So we don't really know for sure who's at risk for getting them. They can kind of happen to anyone at any time in the disease course. And again, if you can catch them early, you can stop the medication, the impulse goes away. So that's another fascinating part. This isn't uncovering some deep, dark skeletons in the closet or some hidden desires. This is really when the medication's in the system, it drives these behaviors, and as soon as it's gone, it stops. But for probably the biggest reason why, when we talk about it with patients, about why they choose not to be on these medications, is the fear of having something like that. So that's always something to be aware of. Doesn't necessarily mean you will. And certainly doesn't necessarily mean you'll get a bad one, but it's important to maintain that vigilance, because if you catch it early, you can kind of get out in front of it and it's much less of a problem. So just to kind of highlight a little bit in that direct comparison between the two, again, levodopa's problem, risk of dyskinesias. So the dopamine agonists are going to be your sleep attacks and your impulse control. But as you can see, otherwise, there's a lot of overlap. So why do the dopamine agonists cause the impulse control issues, but levodopa doesn't? That gets back to what we talked about before about these reward pathways in the brain. Those dopamine agonists do not care where dopamine is needed. So when we give levodopa into the brain, the only cells that pick it up are the cells starving for it, that want to make more dopamine. So those cells in the nigrostriatal pathway are starving and they want more dopamine. So they're the ones that pick up levodopa. The reward pathway is like, I'm good. I have all the dopamine I need. So I'm not picking up any extra. The dopamine agonists, because they bypass all of that and go straight to the punchline of the postsynaptic neuron, they're going to stimulate every dopamine receptor in the brain. And that's why that induces that reward pathway overstimulation and leads to these impulse control disorders. So that's why it's unique to this class of medication and not levodopa. So that's kind of like the next big class in terms of the big guns. So now we'll kind of start going through those kind of less efficacious, but thankfully also less side effect medications as well. And so next are these class of these ones that prevent the breakdown of dopamine. And so we can kind of see here, the first one is in the bloodstream. So levodopa is constantly being chewed up as it makes it up to the brain. And so we can actually add a medication called a COMT or COMT inhibitor that basically stops that breakdown, essentially allowing levodopa to make it successfully up to the brain before it gets chewed up. The other way that we can do that is inside the brain itself, where we have an enzyme or protein called MAO, or monoamine oxidase. And that is what's responsible for kind of chewing up the dopamine and allowing that synapse to get cleared out so another batch of dopamine can kind of be released for the next message. So in the blood, COMT blocks that breakdown. In the brain, MAO inhibitors block that breakdown. So we can kind of either do it in the blood or the brain to kind of stop that breakdown, enhance that dopamine that's still around. So the COMT inhibitors, the most common one is entacapone or Comtan, and there's a few different versions that I have listed here. Most people do not use tolcapone because that one unfortunately requires blood monitoring with liver enzyme checks. But you still see picapone is another new one, which is kind of a long-acting version of it. Essentially, that's what they do, and what the real efficacy is it can kind of extend the life of levodopa by about maybe 30 to 60 minutes around each dose. So it's certainly not going to be a home run hitter. It's not going to be equivalent to how strong the levodopa or the dopamine agonists are. But if you're pretty close, if your levodopa is almost right, then this can be what you can add into the mix to kind of fine tune it. The side effects are essentially what it does is increase levodopa. So it's the same side effects we just talked about. Just less potent to have them. And the kind of the goofy one is it can actually change the urine, kind of a bright orange, and kind of see the pill color right there. So that sometimes can scare you. If you start this and all of a sudden your urine's changing colors, but it's just the coloring in the dye of the pill. Perfectly harmless if it does happen. So again, not a bad solution if you're like, my regimen's pretty close. I just need a little bit of fine tuning to kind of get it fully optimized. And then the MAO inhibitors basically behave the same way. Again, they're just breaking it down in the brain. So these go by rasagiline and selegiline are the two big ones. And essentially, these can be taken with levodopa or essentially without, because this will also keep whatever your brain's still producing naturally around too. So whether it's your artificial levodopa or your natural produced dopamine. And the nice thing about these, and probably why we use them a lot, rasagiline's once a day. So it's kind of nice, this one pill a day, and it can kind of help stretch things out by about an hour or two less off time throughout the day. There's actually some evidence too that selegiline breaks down into a version of amphetamine. It's not actually like the amphetamine that you would see as like the street drug, but it's very, very similar. It's important to note too that it will test you positive for amphetamines on a drug test. So if you're still working, or we have some long haul truck drivers and those kinds of things, that's obviously very important if they all of a sudden fail a drug test. So it's important to be aware that these medications will screen positive. But that can actually help for fatigue. So sometimes we will try this in rasagiline as well, even though also has some benefits for the daytime fatigue too. So that's where you might kind of see it used if you're having issues with fatigue. Again, not as potent, not as beneficial for the motor symptoms as levodopa. So this is kind of, again, a more like fine tuning. I'm close. I just need to take the edge off the symptoms. And then the other important thing with these medications, what does come up, is it does interact with over-the-counter cough and cold medications. It's impossible to keep a list of all those because every single pharmacy has their own version of it. Walgreens has their version, Costco has their version, Walmart has their version. So there's thousands of names that all basically are the same product, Sudafed and all these other different things that are basically the same thing. So if you're on rasagiline or selegiline, the most important thing to do is talk to the pharmacist in the back of the store or whatever pharmacy you go to. And just be like, I'm on this drug. Which over-the-counter cold medications can I take? And they'll gladly point out whichever ones are safe to do. The misnomer that comes up with this, I like to talk a little bit about it, is the way that medications work in terms of their labeling is that if you have a medication that's in the same class as another medication, like another MAO inhibitor, any MAO inhibitors all carry the same label warnings on them, unless you actually fund a study that says, no, my MAO inhibitor is different than the others, which costs millions of dollars. So most pharmaceutical companies are not going to pay them out that amount of money, and there's no private or funding that's going to be able to cover that either. So essentially, they're kind of stuck with that labeling. And that's important in this class because in the early 1900s, there's other MAO inhibitors that work on another neurotransmitter called serotonin. And serotonin is involved in things like depression and anxiety. So you think your antidepressant medications work very similarly to this. So those MAO inhibitors, those ones from the early 1900s, interact with other antidepressants around serotonin. These ones don't, especially at the doses we use for Parkinson's. These ones work with dopamine, not with serotonin. However, they still carry that label that they could interact with serotonin. So not uncommonly, if you're on an antidepressant and your doctor prescribes you one of these, you're going to show up to the pharmacy and then be like, did your doctor explain that he's trying to kill you by having you be on these medications together? And so we'll get the call from our patients freaking out, being like, the pharmacist told us, like, oh my gosh, I can't take these together. Perfectly fine. Now, unfortunately, we cannot take that label away. the pharmacists are usually either not educated enough or have to kind of honor bound. They have to read you the letter of the label. They can't really kind of say, yeah, but don't worry about this one. So we tell all our patients before they show up about that, but not necessarily everyone's aware of that issue that comes up. So again, perfectly fine to take these together with antidepressant medications. So just in case that's ever come across or that ever does come up, not an issue. So that's kind of at least a run through of some of the other medications around dopamine. Now we're going to kind of talk about the other pathways, the other circuitry that kind of surrounds dopamine that we can take advantage of. Think about these like if the highway's all backed up, these are the side roads that we can take to sometimes navigate around the issue. So we can kind of see that here where we saw our main pathway coming through. And if this is damaged, well, what about taking these routes that can kind of bypass and modify? So these are other neurotransmitters, such as acetylcholine, NMDA. Don't worry so much about the names, but essentially other neurotransmitters that work through different pathways to kind of modify those dopamine pathways. So kind of backdoors is another way to think about them. The first class that you guys will sometimes hear about are anticholinergics. And most of us as the experts don't use these anymore because they can cause permanent cognitive impairment or dementia. So if you're on any of these and weren't aware of that, it's important to talk about with your providers about that risk. Most commonly, trihexyphenidyl or Artane is the one we use, sometimes benztropine. But that's the thing. We know it can make cognition worse in the moment. What the evidence is starting to emerge is that it can actually be permanent. So that's why we don't really use these much anymore. The other class of medication, though, are the NMDAs. And this is where amantadine comes in. And amantadine has a few long-acting preparations that you can see here. Basically, all kind of the once daily versions of amantadine. What it's really good at is treating those dyskinesias. So almost always when we're using amantadine, it's because patients are either having concerns or having those levodopa-induced dyskinesias. And then we can actually use amantadine to help treat that. It's kind of a fascinating story. What amantadine actually is an antiviral medication. It's actually an anti-flu medication. And you guys may have been familiarized too with COVID and everything, how the strains of most flu bugs change. That's why you have to get your flu vaccine. It's a different one every year because it's rapidly changing. And so amantadine, unfortunately, is no longer effective against the flu. But the versions of it back in the 1970s, where it was effective, how they actually figured out that it helped Parkinson's is they kept giving it for the flu, and all the Parkinson's patients that had the flu got better, and their Parkinson's symptoms improved. I'm like, wait a minute, what's going on here? And sure enough, they figured out that amantadine was actually helping to treat their Parkinson's symptoms. So that's where all that comes from. It can also sometimes be used primarily to treat the Parkinson's symptoms itself. So it can actually be used sometimes before or without even levodopa. But most commonly, it's used synergistically to curb those dyskinesias. Unfortunately, it does have side effects. It can kind of, especially if you're having any cognitive impairment, confusion, or psychosis, this can make that worse. The other thing is it can induce insomnia. So you want to make sure that if you're taking it multiple times a day, you're not taking it within about 6 to 8 hours of bedtime. So you're taking a second dose early in the afternoon. It could also cause this rash. As you can see in the picture here, it's called livedo reticularis. Harmless, but obviously pretty disfiguring. And reversible. So sometimes the patients develop this rash and it's bothersome to them, then we can stop the medication, that gets better. So again, pluses, treats dyskinesia. Minuses is that it can worsen the confusion or psychosis. So oftentimes might have some side effects about why patients can't stay on it. And then the last kind of workaround is what we call adenosine receptor antagonist. So adenosine is another neurotransmitter. And this is one that actually, interestingly enough, was discovered. Maybe I don't know if Dr. Solis-Cohen talked about this, but you guys might have heard about it as well, that caffeine drinkers are less likely to get Parkinson's disease. It's completely irrelevant once you have the disease. Caffeine really doesn't do anything to prevent further progression. But essentially, that kind of got researchers thinking about, well, what's going on there? Is there something to that? And so they basically made a medication that works on the brain cells that caffeine works on, called adenosine receptors. And And so that's how this medication kind of bypasses dopamine, as it works on these adenosine pathways. Similarly to what we just talked about with the COMT inhibitors, with the MAO inhibitors, it takes about 45 minutes to about 90 minutes or less off time per day. It's nice. It's a once daily medication as well, very similar to those. Its side effects are pretty much just more mild versions of levodopa. It can still induce dyskinesias. It can still cause nausea, lightheadedness. It's just less likely to compared to levodopa. Yeah. So again, another one that can be used as similar to the CMT or the MAO inhibitors, as yeah, my regimen's pretty good. It's almost there, but it's not quite all the way there. Yeah. This is another one where, especially if you're having side effects, like for example, the upset stomach, that you might try like this class of medications instead, to kind of see if you can get further benefit. So that's kind of our tour de force through the different medications. I do want to kind of do a check-in here. Any other questions about the details of the medications themselves? And then these are my two emotional support animals, Theo and Daisy here in the picture. Maybe someday I'll train them to sniff out Parkinson's too. That's a fun little aside about the different studies looking at how dogs can smell Parkinson's, if you guys are ever curious about that. But
I did hear something about that, but my question is back to the antidepressants briefly.
Mhm.
And I know just like in Parkinson's, every person, their symptoms they're different, how they may or may not react to the medication. The folks that we see that may need to be on a Parkinson's drug and an antidepressant, if they were seeing you, what would be your discussion with them about that?
Yeah, are you talking about specifically if they were on an MAO inhibitor?
Yeah.
Yeah, that we would just start the antidepressant and not worry about it. Yep.
Okay.
Yeah, that's what I mean. It's kind of interesting. The researchers always come up with fun names for their trials, or basically turn a bunch of words into an acronym.
Yeah.
So the study is called the staccato trial, which is a long-winded way of saying like had multiple therapies of being on levodopa, on the MAO inhibitor plus being on the antidepressant. There's several thousand incidences in that study of patients being on both, and 0 cases of serotonin syndrome.
Okay.
It hasn't happened yet, despite thousands and thousands of cases of patients being on both.
Okay.
Unfortunately, since it's not a direct study to look at that, it still carries that label. So the pharmacist still has to read you the riot act when you pick up the medication. But that's one nice thing, though, is realistically, any antidepressant we want to use is available to us for Parkinson's, and can also be pretty effective for Parkinson's. So that's actually a good new situation. Pretty much anything that your psychiatrist or primary care or your neurologist would want to start you on is available to you.
Okay. So encourage the constituents to go ahead and have that conversation because it may be available to them.
Yep. 110%.
Great. Thank you.
Any other questions before we kind of switch gears to talk about how the heck we decide which medications to do and when? All right, we'll dive into it. So again, we kind of remind ourselves, well, here's our list. And again, kind of broken down those 2 big categories. The kind of bigger bang for your buck, but also potentially more side effects, or less efficacious, but also less side effects. So those would kind of be your fine tuners and kind of work in between, especially if you're having side effects from the levodopa or the dopamine agonist. And you can kind of see like this, the good news, the good problem that we have is we got a lot of choices. So how do we kind of come up with a decision about what to try and when? Well, there's some general rules of thumb that I think are important for everyone in here to kind of keep in mind. Everything we've talked about today and we'll talk about is not disease modifying, meaning it does not change disease progression over time. So this is for symptomatic relief. So if you're bothered, you want it to be on these treatments. If you have a symptom, like we talked about with the dyskinesias, where they don't bother you, why the heck are you taking a medication for something that doesn't bother you? I had a patient sum it up nicely one time. these are like really good cough drops. You know, you don't have to take a cough drop. It's not going to treat the bacterial infection that causes your cough, but it sure takes the edge off the annoyance of it. So that's what these medications do. So it's very, very important to keep in mind, if you're having symptoms that aren't bothersome yet, you don't need to be on a treatment, or you don't need to change treatments. You only really have to go after the symptoms that bother you. The flip side of that is also true. Like we talked about, I think I want to stress, if you have a symptom that's bothersome, there's no reason to suffer. There's no reason to wait and keep the medications on the shelf and be like, well, I better be way worse before I break them out. The whole point is, if you have something that's decreasing your quality of life, take the cough drop, take the pill. So that's important to stress. All side effects are reversible, meaning that it's okay to try. It's okay to experiment and see how it goes. Because worst case scenario, if you have a side effect, you can always lower down or stop the medications and get rid of it. So it's important to kind of feel comfortable being like, okay, I can go for it. And worst case scenario, if I don't like it, I can reverse course. And the other thing that I think that Kim just mentioned perfectly, and there's no one way to treat Parkinson's. Everyone's unique. A patient summed it up nicely. You're all snowflakes. No two exactly are alike. So it's important that there's always multiple right answers. So I think sometimes we like to think about it, oh, there's one answer to this. There's one best possibility. No, with Parkinson's, we got a lot of right answers. That's the beauty of this. So you might talk in your support groups and everyone's on a little bit of a different regimen. Guess what? Because they all work. So that's the good problem that we have. So the most important thing is for you as an individual to be like, are my medications meeting my needs? Am I treating the symptoms that bother me as effectively as I can? Am I mitigating side effects to my satisfaction? That's the important thing. If you try to compare across other patients, you're going to quickly see the disparity between one patient to the next because, again, we have multiple right answers. And the most important thing that I can't stress enough is that shared decision-making is the whole kit and caboodle here. You, as an individual, tell your physicians what bothers you. We cannot intuit what is going to be an annoyance to you. So it's important before you see your physicians or providers that you spend some time thinking about what are the things that bother me? What are my bothersome symptoms? And I also would put a plug, even if you think it has nothing to do with Parkinson's, bring it up. Because there's things like postnasal drip that you would not really logically think have to do with Parkinson's, but absolutely can come from it. So those are always important to kind of do a list before you go in, because you're going to get asked. If your physician is a Parkinson's expert or understands Parkinson's, the first thing they're going to ask is what bothers you. Now I see a tremor, let's get rid of it. It's going to be, does that tremor bother you? I see you have dyskinesias, but do they bother you? So that's going to be the most important piece, that you spend some time thinking about that. What are those different symptoms? So you're not caught off guard being like, well, I don't know, doctor. I'm not sure what bothers me. I'm gonna have to think about that. Because then you kind of miss the opportunity to talk about it collaboratively in the moment. So I can't stress that enough. Shared decision-making is so, so important to this. And essentially we repeat this cycle. So what we do is we have that ongoing discussion of what bothers you, what are your goals. We discuss our different options to address those issues. Then we make a decision. We start or change the treatment, and then we check in. How do we do? Do we achieve our goals? Do we have side effects? Do we kind of get part of the way there, but not all the way there? And then we kind of rinse, wash, and repeat over and over again. That's the secret sauce here with this. So again, as much as you guys can be kind of active participants in this, the better and quicker the outcomes are going to be. To give you guys just a couple examples of what I mean by those discussions and how they kind of lead to different decisions. So I have a patient, and this is kind of especially around here in Colorado, hopefully some of you identify, 67-year-old, pretty avid skier, tennis player, was starting to have difficulties doing those. And so after we discussed, he didn't want to kind of nickel and dime it. He wanted to kind of get to the punchline. Let's get on the medications that are most effective so I can keep performing at my absolute best. I don't mind having some side effects as we can mitigate those because I'm going for like true performance. Then I had a very unfortunate 37-year-old, and she was doing a lot of public appearances for a nonprofit. And it was kind of a sad story. Her video would get posted online, and all the comments would be like, "Wow, what kind of drugs is she on?" Because she was having dyskinesias. And so she was very concerned about that because everyone thought that she was on crack or cocaine and all these other kinds of nasty things. So to her, because of that public appearance, it was a pretty big deal to avoid that. So we actually use other medications for several years to mitigate the risk of those dyskinesias. And that worked perfectly for her. Then, inevitably, after a few years, her symptoms progressed, and then we started on levodopa, kind of the bigger efficacy medications. So that's just one of many examples of kind of talking through what are those risks that really are important to you as an individual? What are the side effects that concern you, and what are the treatment goals you're looking? So other ways to think about that too would be like, yeah, my symptoms are only kind of mildly bothersome, so I don't want to take a medication 3 times a day. But yeah, one pill in the morning, yeah, I'll do that. I'm kind of willing to do that to start. And so we might start you on something like the rasadolene as opposed to levodopa. Yeah. Versus like I can't function the way I want to. I'm trying to go out skiing. Rasadolene is not enough. I need something stronger. So that's where we might go to levodopa. So there's many examples of kind of that collaborative decision making about why I would choose one medication versus the other. Just to kind of, I put a plug at the start, but kind of again, this could be a whole separate talk about all the other treatments for non-motor symptoms. And as you see, depression, like we talked about the antidepressants a second ago. So by all means, this is something that as you go to support groups and other talks, this is another topic that we can kind of delve into in much more detail about how do we treat these non-motor symptoms as well. So lastly, I want to kind of impart the idea about advanced Parkinson's disease. So hopefully none of you are at this stage yet. And this is something, unfortunately, though, will occur at some point.
Hey, good job out there. Thank you. Yeah, definitely. You look great.
Some other people I forgot to mute. Okay. I think we're good. Yeah. So advanced Parkinson's is later in the disease course, and it comes through many different definitions, and there's actually a lot of disagreement amongst the experts about what actually is advanced disease. The way that I like to kind of think about it is when at the earliest start of your disease, and hopefully many of you are still here, I like to kind of think about it as almost the honeymoon phase, because you kind of get away with anything. It's like I can still do most of what I want to do. I can take my medications. I miss doses. Yeah, it's not a big deal. I take it once a day or I take it 5 times a day. Not big changes either way. And then eventually, as you kind of enter into the later stages of the disease, you kind of notice more. It's like, man, if I don't have my medications optimized, if I miss a dose or if I'm late for a dose, well, I don't get away with it anymore. I get a functional impairment between when my medications are working and when they're not. And that's what we refer to as a motor fluctuation. Other terminology with that is what we call those on periods, or when you're feeling good. Medications are working, you're in that sweet spot. Off periods are when they're not enough. The tremors are there, the walking troubles, the slowness, the symptoms are worse. The peak dose effects is like, again, what we refer to as too much. Those are those dyskinesias that we were showing earlier. Yeah, I mean, you can have different types of off periods. It could either be like when you first wake up before you get your first doses. It could be that you don't make it to your next dose. It could be that it takes too long for your medications to kick in. Or unfortunately, in some cases, it's just like most doses work, but some feel like a dud. You take your pills and it's like nothing didn't kick in this time. So unfortunately, all those things are possible. And so what I would hope that, again, most of you are not at this stage yet, is to kind of do a couple of good practices to hopefully prevent that stage of the disease for as long as possible. So even though right now you could get away with having some bad habits of not taking your medications consistently, playing the game of, oh, why don't I wait till I'm miserable and then take a pill to get me out of it? What I would encourage for you is this is a good time to get into those good habits. Because again, right now, your brain still has some storage capacity sometimes where you can kind of get away with being a little bit all over the place with your medications. But that storage capacity is fleeting. Fluctuations will happen. So studies will estimate it's about, there's one that was at 15 years, one at 20 years, 100% of patients had those fluctuations. The average is about 2 to 7 years when you start to notice that kind of, ooh, if I'm not optimized, I can feel a functional difference. If you get into those good habits now where you take your medications on a regular schedule, kind of space them out every day, it's every 4 hours, every 5 hours, whatever it might be that works for your schedule, you prevent those potholes from occurring and you get out in front of it. And it's way easier to keep yourself from going into a hole than to dig yourself out of it. Meaning, if you let the symptoms happen, you start to feel more miserable. That actually increases the amount of dopamine you need to treat that symptom. Versus if you take it before you have the symptoms, don't let them happen, you don't end up in that kind of that snowballing effect. So you don't need as much medication to prevent the symptoms. Yeah. So this is that time to practice. It's okay to make mistakes, but this is that time to get in that good habit because you're going to stave off those fluctuations for as long as possible. Okay. And again, just to kind of highlight that here, hopefully many of you are over here. But as you start to enter these other phases, yeah, you can't get away with missing doses. You have to be a lot tighter control. And then last but not least, what can you do about those motor fluctuations? What do we do when we enter this kind of rock and a hard place where it's like, yeah, I want to be able to increase my meds, but now I'm having peak dose side effects. What can I do? Well, I can't lower my meds because now my symptoms aren't controlled. So now I'm kind of stuck. Like, where do I go next? That's where we have a lot of different choices. And I would encourage any of you or anyone that you talk to that has Parkinson's, if they're not seeing a movement disorder expert, they're not seeing a Parkinson's expert, if they have motor fluctuations, this is an absolute time to make sure they're going in to see a Parkinson's expert, not a general neurologist, not a primary care, not a neurosurgeon. They're seeing a Parkinson's expert because there's so many options we have here. There's a lot of right answers that this is where a general neurologist is not going to be as familiar with all the different options we have. And again, the stakes are higher. You can't afford to just do whatever anymore. You're not going to get away with it the way you used to. So this is the time to make sure you have an expert on your team. In the early stages, again, not necessarily 100% needed, but this is the time to do it if you haven't already. So hopefully if you guys are already here, or if you get here, that you already have a Parkinson's expert in your corner. And again, just I want to kind of briefly introduce, because this could be a whole separate talk, but this is obviously very popular conversation amongst patients or amongst the Parkinson's community, is these interventional treatments, these surgical options that help us when we reach that motor fluctuation stage. Things like deep brain stimulation, which has been around the block since the early 2000s now. And essentially, when is the timing of these procedures, like we talked about, is when you start having these motor fluctuations, when you're not able to quite get away and you're stuck in that rock and a hard place. So just to briefly kind of talk about why you would want to get DBS, is to reduce medication side effects, kind of reduce the medication burden to not need to take as many pills. Or the one exception of symptoms is tremors. So deep brain stimulation only does as good as your medications do. Okay, it doesn't improve upon what your medications do, with the exception of tremors. So if you are a patient that has a lot of bothersome tremors, like we talked about before, that remind us of this slide, sometimes those oral medications aren't so hot for the tremors. So deep brain stimulation is one of those times or one of those treatments that can help you work around if you're in that 40%. But I think probably one of the biggest misnomers of it, oh, my medications don't treat my symptoms that well, so deep brain stimulation will do better. That is not true. Again, medication responsiveness can be reproduced by DBS. It's just more consistent. So you won't have those wearing off periods, those fluctuations as much. That's what it helps with. Okay. And then again, the other big thing that it does have, unfortunately, not so great coverage for the non-motor symptoms. So it certainly would not be a reason to get DBS if your non-motor symptoms are your issue. And it can, in addition, make cognition and memory worse. So that's something that we screen for. As you can kind of see here, dementia is one of the big things. Probably the saddest thing that we see with deep brain stimulation, or especially patients that have gone through with it already, is if they went through it and had unrealistic expectations. Like, for example, they expected their gait or walking to improve, or they expected their symptoms that don't respond to medication outside of tremor to improve. And then they get a surgery, and it doesn't matter what benefit they had, they can't meet their expectation, and it's a failure. So I encourage you, make sure you're seeing a movement disorder neurologist who can talk to you about, is deep brain stimulation an option? Is it appropriate for you? So not a neurosurgeon, not a general neurologist, a Parkinson's disease expert to talk you through. Because again, for many patients, this is the right choice. And you can do all your homework ahead of time to know exactly what you're signing up for. Then you get the outcome you're looking for. But those are the cases, especially when we're at an academic center like we are at University of Colorado in the Center of Excellence. And we unfortunately get to see all the patients that got told the wrong things or had the unrealistic expectations, got the surgery, and then come to us desperate for like, why didn't it work? And we have to tell them because it was never going to. And you got a surgery that was never appropriate for you. So those are obviously pretty sad cases of that. So if you ever reach this, again, can't stress enough, this is the time to get in and talk to one of us to go through that. Is this an option for you? Is this something that would make sense for your particular case? And then the other kind of big one that's coming up now more often, and it's kind of skipping ahead. I put these in here just in case questions come up mostly, is the MRI guided focus ultrasound. And so essentially what is this doing? It's burning a permanent hole in your brain using ultrasound waves, where essentially we concentrate them in one area. It kind of burns a hole. So that can be used in certain situations, but it's really only used for right now for Parkinson's is for tremor. And it is not really ready for prime time yet for the other symptoms. And to give you guys an example, it has a 30% failure rate to go after the other symptoms. So you get a permanent hole in your brain and you have a 1 out of 3 chance that it's not going to work. Yeah, that's not really what you want your odds to be. But if you have bad tremors, this could be something that can be considered for your Parkinson's care as well. And with that, I'll kind of wrap up, but I certainly am available in the last half an hour here to talk about any other questions that you guys have. And again, just to kind of find a couple key points. And one thing that's always really, really nice, especially if you're seeing new providers, never a bad idea to have a kind of a master list that you guys keep for yourselves of what are your medications, what time do you take them, and why do you take them? So having a kind of list for you would be like, this is what I'm doing. This is why I take this med. This is why I take this one. And then the other thing to do is always bring that list with you whenever you go into any medical provider. So bring it with you. It makes life a lot easier because otherwise we're going to ask you details. We're going to ask you all what time do you take it, all that. And it makes it impossible for us to tell you what to do next if we don't know what you're doing currently. So I can't stress that enough. If you're on the medications, keep a working list of them so that it makes the life a lot easier when it comes to see your providers. And last but not least, exercise, 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 because that is the most important treatment that actually slows down disease progression. All right, so I see the questions flying in already. So the first question was, I'm hard of hearing and investigating cochlear implants. How does that align with my Parkinsonism? Really minimally. There's no contraindications at all from doing the cochlear implants, except for the fact that it could make doing some of those surgical procedures more difficult. But again, even if that's the case, in some instances, patients have gotten their cochlear implants removed if it really made sense for them to get the deep brain stimulation or the focus ultrasound. Or there's other options like we talked about, the medications that can be considered. So certainly, cochlear implants would not be a contraindication at any point in Parkinson's. Taking anti-anxiety drugs at different times from carbidopa-levodopa. That's actually a good point. Carbidopa-levodopa, thankfully, what's beautiful about it, and you guys probably picked up on it, it does not have drug-drug interactions. It does not require you to get liver checks or blood work done or anything about it, like some other medications might do. So it's really easy to use. That's one of the advantages we have. It can be taken with any other medications, and it's just fine. The important thing would be like if your provider says this medication needs to be taken on its own, like thyroid pills, that's true for any medications. It cannot be taken with anything else. But levodopa has no restrictions to that. You can take it with or without food. It could be taken with other medications, no problem. And then is there any reason to take levodopa at night when you're asleep? Yes. Many times patients don't need to at the start. It's kind of a fascinating phenomenon. We call it sleep benefit, where for whatever reason, sleep kind of partially treats the symptoms. especially early in the disease course. So most commonly at the start, you take it just when you're up trying to move around to improve your movement while you're trying to be active. But inevitably, Parkinson's becomes a 24-hour disease. So at some point during most patients' disease course, they'll have more trouble sleeping. They'll kind of like wake up in the middle of the night and have a hard time getting back to sleep. Yeah. In which case, very commonly, that's when we'll start doing levodopa to cover you through the night. Yeah. So that is something that absolutely is kind of on our usual suspects of asking about how sleep is going. Yeah, to accommodate for that. So very reasonable if you're having sleep troubles or you're waking up several times to use the bathroom at night, because your bladder's a muscle just like your other muscles as well. So if you don't have levodopa in the system, then your bladder can also act up too. So that's another way to kind of calm down. Having to urinate frequently at night as well. What else?
Are there any more questions? There's one.
So like taking levodopa when you wake up is also an option. Most patients prefer to do that. Because again, a lot of times when you first start the day, especially like for you're not, even if you take it at bedtime, like we talked about before, levodopa lasts about 4 to 6 hours. So inevitably it's going to wear off at some point through the night. Yeah. In which case, if you're sleeping 8 hours, yeah, by the time you wake up in the morning, it's going to be kind of out of your system. Yeah. So essentially, if you have a 24-hour day and you have a drug that works for 4 to 6 hours, yeah, inevitably you can get to the point where you're taking it 4 times a day, 3 times while you're awake, and then 1 time to kind of cover your overnight. So while it's in your system while you're sleeping. Otherwise, if the drug leaves your system and you feel off, you'll have trouble sleeping. That's what I mean by covering with levodopa, if that was confusing, is that you have levodopa in your system to control your symptoms. Yeah. So sometimes if that leaves in the middle of the night, a lot of patients will be like, oh, I go to bed at 11, I'm waking up at 2 a.m. And it's because they'll take a dose of levodopa at bedtime and it wears off in the middle of the night, like kind of 3-4 hours into it. Now they're awake for the rest of the night. So what do you do in that situation? You take a dose when you wake up in the middle of the night to cover you through the rest of the night to the morning. So the idea is that when you're having off symptoms for Parkinson's, you kind of match your levodopa. So you always are having doses to cover when those off symptoms are occurring. And again, for every patient, that might look a little different. And that's where we have those discussions about your symptoms at every follow-up visit to be like, when are those off periods occurring? And so how do you know when the off periods are occurring? If you take your meds consistently on a daily basis, then that makes it really easy to identify when the meds are working, when they're not. So that's another plug to try to get in those good habits, because then you can tell where those gaps are, and it makes our guess of how to fix that very easy. If you take your meds different times, different amounts every single day, you can see how it's really difficult then to troubleshoot and come up with how to fix the problem. So another reason why you can try and get in those good habits. Too much Cinemet is the side effects. So there is no limit to how much Cinemet you can take, or levodopa. And the limit is going to be how much you can tolerate without having side effects like those dyskinesias we talked about. So inevitably, how would you know if you're having the side effects? That's how you could tell if you're taking too much. But unlike other medications where it's like, oh, you can't take more than 8 pills per day, there's no such limits with it. It's going to 100% depend on how you tolerate it. Great question.
Are there any more questions? Guess not. Okay.
All right. Thank you, guys. Thank you so much. And everyone, have a good rest of the evening.
Thank you so much, Dr. Hawkins. And thank you everyone for coming. And just a quick announcement. The third session of our PD 101 on exercise is on April 9th. So I hope to see you there. And again, thank you so much, Dr. Hawkins, and thank you everyone for coming, and have a great night.
Thanks, this was great. Appreciate it. Hi, Phyllis.
Thank
Hi. How you doing?
I'm good. How are you doing?
Good, good.
Yeah, yeah, it was a really good presentation.
Yeah, very good. And is everything still set for tomorrow? For me?
Yes, yes,
And Friday?
yeah, we're all set to go. So tomorrow is, hang on, I'm recording this. Let me
Oh,
turn the recording
okay.
off.
Sorry.